Thank you, Dan, and thanks for that, coming all the way from London for that talk as well. We're excited to have you here. Yeah, I'm going to talk a little bit about how we model and validate economic justification. Anyone who's tried to bring new technology into their hospital or make changes in their hospital, there's always going to be a question about, well, does this cost money and how do we make that happen? That's my disclosure. So Dan and I actually helped author a paper about this this year about how we're really at a time where it used to be probably in Dr. Engelman's career, he could just ask somebody for something and he got it. But nowadays, you have to do a little bit more work around the economic validation of things because hospitals are a lot more tight on their budgets and it's much more difficult. And so what we talked about here is how to use value and healthcare value in that value analysis process. One of the problems is in the last several years and maybe even longer, hospital budgets have been divided up into their silos, whether it's cath lab, pharmacy, OR, ICU, and each silo is focused on the cost. What is the exact cost of this product today in my budget silo? And it's very difficult to have that conversation if you're talking about what we're going to talk about, patients' recovery all the way after they go home, so that maybe an OR budget person, even though they care, it's not really their responsibility to worry about spending money to make something happen a month later. And so this has been a big problem around not only in our country, but in Europe and other countries as well. And really what we're talking about now is focusing more on healthcare value. And if you define healthcare value, as Michael Porter did in the article that really led this for a lot of legislation and a lot of patient advocacy, it's the quality over the cost. And so the best possible quality for the least amount of cost from the patient's perspective. And so it happens over this continuum of time. So it's not just what happens in the hospital, but it's through that discharge. And in that article, he talked about the promptness of postoperative recovery and the return to active lifestyle. So when we say, hey, listen, we're going to spend some time and money in the hospital, it's hard to have that conversation within that budget silo for this purpose. And I think that's where a lot of us are running up against barriers there. And really, what is going to drive that to change? And also, when you think about this from the patient's perspective, this was from Time Magazine a few years ago, but patients have copays. Patients' daughters have to take off time and sit with their parents when they're in the hospital. It costs them a lot of money. So when somebody has a complication, when somebody has a prolonged hospital stay, when somebody has to be readmitted, that has a big impact on people's own financial stuff. So not only do we have to do this to improve the health of our hospitals, but also on behalf of the patients. And sometimes I hear people say, yeah, but we get paid for taking care of complications, so you know, what's the big hurry to try to reduce that? But this is changing. Is this the,
yep.
This is from the MIPS and the MACRA, which many of you guys may be aware of, is how Medicare is going to be paid increasingly in the next couple of years. Every one of the doctors and every one of the hospitals is going to get a grid like this. The upper right-hand corner is high quality, low cost. The bottom is low quality, high cost, and the other two grids are everything in between. If you're in the two in-between grids, great. Then you're not going to have a cut in your pay, but you're also not going to have an increase. And I'll show you, it's a zero-sum game. They are going to take money from that low quadrant and shift it to the people in the programs in the high quadrant. And it's going to be on the internet. So that little thing that says you is going to have your name on it. And so this isn't just about all the other reasons. It's going to be part of your public report card, and this is coming out. When? This is that MAPS and MIPS, and we call this a zero-sum game because what they're going to do is starting in 2019, take the money from the bottom 4% and give it to the people and groups in the top 4%, and that's going to increase up to 9%, so an 18% spread. But also, there's a little supercharger in here. They have a $500 million fund for the super performers. And so it's actually going to be another up to 27% on the top end. So not only do you not want to be punished and end up in the low grid, if you're a high achiever like most people, you're going to want to be in that top group, which is going to bring more resources into your hospital and potentially even more revenue for the folks who are on fee-for-service. So this value healthcare is going from a place of kind of theory to the real bottom line. And trying to argue through these silos, I'm hoping is going to become a thing of the past, because it's hard to do this if you're having a budget fight in each little silo. And why do the hospitals kind of struggle with this? This is, I thought, a really good thing. These are the margins, and the green is the margins of patients in the United States who have really good insurance. But the one below the line are all the ones with public insurance, whether it's Medicare or Medicaid. And so the good insurance is kind of paying for the people with the Medicare or the Medicaid. But as that, when you hear about a hospital's margin and how thin it is, the more money they're losing on the tougher patients, often the Medicare or the older patients, the more that's dragging that margin down. So even if, yeah, you get paid to take care of complications, it's a big picture thing, where when you blend it all together, what you want to do is have fewer complications so that you can reduce your costs, and that's not only good for everybody, the patients, but also the hospital and the system. So this is where I think ERAS comes in. We heard some great talks today, the early work by Dr. Engelman. I remember reading that stuff. Fast Track is super exciting. A lot of the early work, and I think that helped lead to ERAS for general surgery. And then the work that you guys are doing in London for one of the first groups to say, well, let's see how we can mold this for cardiac surgery. And as Dan talked about, this group is wanting to take that to that next level. So I'm going to talk about the steps that you take to do an economic evaluation so that you can model benefit. Because we heard a lot this morning, we had a brunch talking about it. A lot of programs are doing this, but it does cost money, and you do have to go to your administration and make this case that you want to put this bundle together and get these resources. So step one is always to estimate the cost of a complication. It could be a cost of a series of complications or one. You could look at AFib and different things. There's big data. This is an example of the Market Scan database. It has 240 million patients in it. You put in the CPT codes. You can find out the cost in general of a complication after heart surgery. Or you can do it on the state level. This is from the Virginia group that does the Virginia Cardiac Surgery Quality Initiative, and they've written some really nice stuff. There may be some people here from that. This is talking about the incremental increase in cost. So when you look at those complications, AFib, mediastinitis, stroke, reoperation, prolonged ventilation, renal failure, all of those incrementally increase the cost by anywhere from $12,000 to $60,000 per case. So that's the cost of the complication, the incremental increase in cost. And then we also know that when a lot of these patients, when they get one complication, they get more than others. So this becomes sort of a geometrically added mathematics to impact the cost of these complications. And I liked this quote that came from this article, but ultimately, any discussion on potential savings resulting from a reduction in the incidence of postoperative complications is incomplete without mentioning the investment required to achieve such goals. You're going to have to work with your hospital. It means, investment's not only money, it's people, it's time, it's administrative resources to get stuff done. We all know that's hard, but that's where it starts. But how do you justify that? Next thing, how much does it cost? What is the cost? And that's the shiny new object that everyone's excited about. But this is the whole ERAS thing where you put together a bundle. And we'll be, over the next couple of days, talking about different evidence gradings of different things that can go into it, whether it's carbohydrate or whether it's temperature or different things that we'll talk to you about the work we've done and also get your ideas. One of the big questions, and I think ERAS is good about this being comprehensive, but one of the things that always comes up is this intervention comprehensive, everyone gets it, or is it selective? We only give it to the people that we think need it. And that's a hard thing to predict, who's going to need something when not everybody has a particular complication. So is this selective? Is it comprehensive? And I like to use the analogy of a seatbelt versus a fire extinguisher. A seatbelt's something everybody puts on every single day. You don't try to put your seatbelt on 2 seconds before your car wreck. We put it on every day. It doesn't prevent all broken bones and all sorts of bad outcomes, but it significantly reduces them. Versus a fire extinguisher, which is something you take out when the problem's already started. And the nice thing I think about ERAS is looking at this more like a seatbelt that we do every day versus something like, oh, that guy's going the wrong direction. Get out the ERAS bundle and let's get that going. Next thing, when you do the math, you need to know the potential % reduction of the complications. And that's simple math. Most of you guys who do research know this, but basically you take the % before versus the % after, over the percent before. So like AFib, if you have AFib that's 30% postoperative AFib, and you do a study and you drop it to 20%, that's a 30% reduction in your postoperative atrial fibrillation. And what I found is looking at this and looking at the different things, that 30% number keeps coming up a lot. It turns out most studies show about a 30% reduction in a complication when you do an intervention. Sometimes it's 40, sometimes it's a little higher, sometimes it's 27. But if we said, let's look at the goals, and we said, let's try to reduce complications after cardiac surgery. We're going to take a day off the length of stay. Let's reduce delirium by 30%. Prolonged ventilation, AKI, POAF, retained blood, transfusion, infection, sternal wound problems. If we can do just that through this combined bundle rather than trying to hit them one at a time, I think that's going to have a big impact, and we'll see on the cost. If you could reduce the cost of care overall in your program with 1,000 patients a year by $2,000 to $4,000 by doing this sort of thing, we're talking about $2 to $4 million staying in the budget for your administrators to be happy with. Okay, so now we're not talking about cost in a budget silo, we're talking about overall healthcare value and savings for the system that should translate into for everybody. And I think that those are reasonable goals for the kind of stuff we're talking about. And you mentioned the aggregation of marginal gains. This is in almost every ERAS talk. It's the progressive accumulation of many minor changes in the correct direction that ultimately leads to a major gain, even though the immediate signal may be may be small. So if we say we're going to take a bundle of these ERAS elements and we're going to try to make a bunch of these things go down, delirium, AKI, infection, it's that aggregation that works together that gets this done, rather than what we've been doing before, which is kind of taking one complication, one intervention at a time. Now, one of the things is, how do you study this? And we had a discussion today with Judson and his team, and talking with Louis about whether or not this is randomized prospective trials, historical controls. You had some great ideas about how to do that as well. But traditionally, we've said everything has to be a randomized prospective trial. And that makes sense for certain things like drugs. But this is really, the intervention here is really a protocol or a behavior. It's kind of hard, like you were just mentioning, it's kind of hard to randomize team behaviors because teams are working together. But this is where real-world clinical pragmatic trials come in, and I think are a little bit better because there's not as much exclusion going on. You have some consent benefits. It might be a little bit easier to not have to get consents. And you're testing a much bigger population of people. The FDA is pushing for this. The NIH is pushing for this. And so I think being open-minded to the way that we do this is helpful. I'm just going to take you really quick through this. This is just a typical spreadsheet. You take those things I just talked about. You define how much it costs, or what the percent is, how much incremental increase it costs, how much it costs you to do it. You put it into a spreadsheet, and you can start to see with that 30% reduction how much you could potentially save. In a program that does 500 cases a year, you could possibly talk to your administrators about, if we put this program together, we can realistically look at saving $1 million with these folks. And we can show you how this, it's hard to do spreadsheets in a PowerPoint, but it's pretty easy math. And then it's something that you implement, and then you look for benefit, and then you implement it again. And everybody's familiar with this care quality circle, but this really lends itself well to that sort of thing. Put the bundle in, see what you like, what you don't like, and do it again, and keep measuring your outcomes. This is just a quick slide. It says the American College of Cardiology and the American Heart Association are starting to look at ways to grade value, and we started looking at that for ERAS as well. And in our paper, we talked about maybe a Class 1 value positive, Class 2 value neutral, Class 3 value negative. And is this something that's been proven or estimated? And what we want to do in the future is get into being able to help you and value analysis committees and us grade the value potential of a various intervention, because right now that's very difficult to do. So in summary, I think we've got a lot of potential to use this as a mechanism to bring value to our programs, to our groups, and to our patients. Thank you very much.